Okay, so finally I'm ready with the medicine session, starting with hypokalemia. Now, in hypokalemia, what you need to remember from exam point of view, one important feature is ST segment depression. Clear? So there is depression of ST segment, and second important thing is a prominent U wave. So these are the two important ECG features which you have to remember in hypokalemia. So ST segment depression and prominent U wave. When it comes to hyperkalemia, the potassium value, the serum value is 3.5 to 5.5 moles equivalent per liter. So any value which goes beyond 5.5 is taken as hyperkalemia, and depending on the severity of the DK, I'll try my level best, but there is nothing like that. Okay, so in hyperkalemia the value crosses 5.5, and as the serum potassium value increases we have different ECG changes, right? But what you need to remember from exam point of view is the earliest is tall peaked T wave, right? So this is the earliest, which is also known as tenting of T wave. Clear? So T wave, now this is the normal T wave, and you can see here it has become so prominent and so tall. Very, very good, Mohammed Anash. And as the value of potassium will increase, you will find some more features like widening of QRS. Okay, so there is widening of QRS, then there will be increase in the PR interval. Okay, so these are other features which you'll find here. So one is of course tall peak T waves, then second is increased QRS, and third is increased PR interval. Clear? So these are the three important ECG findings which you should remember from exam point of view. But yes, of course, at least one should remember tall peaked T waves. Clear? So these are different ECG changes: tall peak T waves, then widening of QRS, and interval PR interval prolongation. Then moving forward to hypocalcemia, there is one important clinical sign, that is cystic sign, where if you tap the facial nerve, there will be contraction of the facial muscles. So this is the classical cystic sign, and this suggests there is neuromuscular irritability. Very good, Mohammed Anash. So this is cystic sign. Now what is more important from ECG point of view for hypo or hypercalcemia is the QT interval, right? So QT interval, and when we say hypocalcemia, the QT interval will prolong, and if we say hypercalcemia, the QT interval will be shortened, right? So in hypocalcemia there will be prolongation of the QT interval, and this QT interval is like calculated from the beginning of Q wave till the end of T wave, right? So this entire duration is the QT interval, right? So this is the QT interval, and this will be more in hypocalcemia, and conversely it will be less. Now this is the QT interval, you can say. So it has shortened here. So this is the QT interval, right? So prolonged in cases of hypocalcemia and shortened in cases of hypercalcemia. Remember this much. Then moving forward to acid base disorders, and here this is all game of PCO2 and bicarbonate. Clear? And the third thing is of course the pH. If it is less than 7.4, or some books might say 7.35. So if it is below that, it will be acidosis. If it moves beyond that, it is alkalosis. Acidosis can be again because of if you say acidosis, it can be again because the normal pH is 7.35 to 7.45. So any value less than it's better we take it 7.35. Clear? liquid 7.35, right? So just to avoid any sort of confusion. So if we say acidosis, or if we say alkalosis, in acidosis either CO2 will be high or this will be low, and converse like this. Clear? So this is how we can get alkalosis or acidosis. Similar, simple just game of PCO2 or bicarbonate. So if I say respiratory acidosis, now acidosis means pH less than 7.35, one thing, and when we are using the word respiratory, it means the PCO2 is high and bicarbonate is normal here. Clear? So this is your respiratory acidosis. Similarly, if I say metabolic alkalosis, so alkalosis is pH more than 7.35. So when we use the word metabolic, so we have to consider bicarbonate, and here the bicarbonate will be high. So raised bicarbonate and no effect on carbon dioxide. Now this is for simple acidosis or alkalosis. Now there sometimes you must find the word compensated, right? So compensated means the body tries to normalize the pH. Clear? So body tries to normalize the pH. So how it will do? Suppose if there is if the pH is less because of increased PCO2, then body will try to compensate it by increasing bicarbonate. So here if you find increased bicarbonate, then it means the body is trying to compensate the acidosis. Clear? So the other entity will be altered to compensate the acidosis or alkalosis, whatever, and the body is trying to normalize the pH, right? So if say if I just put the word compensated here like this, so if PCO2 is high, body will try to increase the bicarbonate. Clear? So to neutralize that, and if bicarbonate is low, definitely it will be lowering of PCO2 here, like that, right? So this is compensation by the other mechanism. Clear? So this is how you might find sometimes a different statement where instead of having this unchanged bicarbonate, you might be having raised bicarbonate. So it means the body is trying to compensate. So in that particular scenario, you must use the word compensated. Clear? So that is the only clause for the word compensated. Otherwise, if you don't find any change, then it means it is uncompensated, or what we write in simple terms like respiratory acidosis or metabolic alkalosis. Clear? So this is very important, and always we have a question from this segment. So even like if you want to see compensation here, so suppose if we are discussing metabolic acidosis, it means the bicarbonate will be less and the pH will be less. Okay, so now how body will try to compensate that? Body will decrease the PCO2, and that is known as respiratory compensation. Similarly, if we take about say respiratory acidosis, where we discuss that pH will be less and PCO2 will be high, so how body will respond? Body will increase the bicarbonate. Similarly, if we take the case of metabolic alkalosis, pH has gone up because of increased bicarbonate, so body will increase the CO2 level to compensate for that. And similarly, if we take the case of respiratory alkalosis, where the PCO2 has fallen below, then the bicarbonate will also be low, right? So and here you need to remember the PCO2 values. Yes, that's very important. So this is again around 35 to 45, and bicarbonate can be remembered somewhere between 22 to 26, right? So these are the normal range which one should remember. Clear? So these are the normal range, and many times we might find the average values here. So here in this graph, these are all you can see average values. Clear? Otherwise, these are, we always mention in the terms of range. Then moving forward to asthma, which is actually airflow obstruction disease, and this is episodic. It means it is not regular. There comes episode of airway obstruction, which usually comes at night or say early morning, and this presentation of airway obstruction, it can resolve spontaneously, or sometimes the patient needs bronchodilator therapy. So these are some important clue to make a case of asthma from a given case history. And there is, of course, because of respiratory obstruction, there is prolonged expiration. Then one should be knowing difference between the obstructive and the restrictive lung disease. Now obstructive is, of course, your asthma, then chronic bronchitis, clear, and also your emphysema. Clear? So these are three important conditions here. Restrictive, you can include interstitial lung disease or occupational lung diseases. Clear? So now what is more important here, as the name suggests, obstructive, so there is obstruction of the airways. So what will happen because of that? There will be limitation of airflow, right? So because there is obstruction to airway. But what is the pathology in restrictive? There is pathology in the lung parenchyma, and therefore there is reduced expansion of the lung because of this fibrosis or any other pathology. So the important conditions: emphysema, bronchitis, asthma, and here you can take interstitial lung disease or pneumoconiosis especially. Then in obstructive, there is pathology only in the airways but not in the lung parenchyma. So the total lung capacity is normal. But in restrictive, airways are normal but the lung parenchyma is affected, and therefore the total lung capacity, which is actually a measurement of the expansion, or you can say compliance of the lung, that is reduced. Then forced vital capacity, because the lung parenchyma is not involved, so forced vital capacity will be normal in the obstructive type. Since parenchyma is involved, so forced vital capacity is reduced in restrictive. Now what is more important for you to remember here is that there is one term FEV1, that is forced expiratory volume in the first second, that is grossly reduced in obstructive type, whereas it is not affected in the restrictive because the airway are okay here. So this is actually a measure of airway. Clear? So since there is a obstruction of the airway in obstructive, so this if FE1 decreases in obstructive type, but here airway are normal. Clear? And therefore if you take a ratio of FE1 to FVC, like this is the numerator here, this is the denominator. So if you take the ratio, it is less than 0.80 or less than normal in obstructive, and it is absolutely normal in restrictive, right? So from exam point of view, you remember please this, because this is the usual framework of question based on this table, right? So obstructive and restrictive, very important from exam point of view, right? So just remember the basic pathology. So this is the pathology here. Clear? These are the examples, and then the main difference is in terms of, you know, FVC, and this is FEV1, and this is the ratio of FEV1 to FVC. Clear? So just remember this much. Then moving forward to respiratory failure. In type 1 respiratory failure, there is hypoxia but without hypercapnia, right? So here there is hypoxia but either hypocapnia or normocapnia. So CO2 is not affected here, but it is in the type 2 where we find hypoxia with hypercapnia. So this is a difference between the two. In the second variety, there is increased CO2, PCO2, right? So here it is normocapnia. Then type 3 is actually perioperative atelectasis, and there is one type 4 as well, which is related to shock. So type 4 is hypoperfusion because of shock. Clear? So type 1, type 2, type 3, type 4. Important thing is type 2, which is having raised CO2 level in the body, and it is because of any condition which interferes with respiratory physiology, or in fact which interferes with respiration. Clear? So it can be from the brain, like central type, where there is coma, intracerebral hemorrhage. Then it can be related to neuromuscular, especially muscular dystrophies or myasthenia gravis. It can be because of obstruction, as we see in COPD or asthma, or it can be in restrictive lung disease, as we see in pulmonary fibrosis or pneumothorax, right? So these are all important causes. So, and this is extra pulmonary mainly, and type 1 is mainly pulmonary, right? And the special the classical example is ARDS here, right? So please remember that. Okay. Sorry. So this is respiratory failure. Then moving to emphysema. Now in emphysema, what happens? There is abnormal and permanent dilatation of gas exchanging air spaces. So gas exchanging air spaces, and these are distal to terminal bronchioles. Clear? So it includes respiratory bronchial, alveolar ducts and alveoli. Now this condition is acyanotic as compared to chronic bronchitis, which is cyanotic. And here the extremely sorry. So here there is no cyanosis, and this is very important to mention. Good morning, Shanawaz bhai. And it is very important to mention acyanotic here, because usually this is distinguished from another COPD, that is chronic bronchitis, right? And what else you see? Well, you see barrel shaped chest. Now what is barrel shaped chest? Normally if we take the transverse section of chest, this is the AP diameter, clear, and this is the transverse diameter. Fine. Now in a case of emphysema, what will happen? The chest will be something like this. So if you take this is the AP diameter, clear, and this is the transverse diameter. So what is happening? The AP diameter is becoming more than the transverse diameter, clear. So this is known as the barrel shaped chest. So please remember this term for emphysema. Now what is more important for you to remember is the radiological features. So these are actually diameters of chest. Fine. Now what do you need to remember? Now look at the x-ray, very classical x-ray. The very first thing which you can see here, it is so much black. So it is known as radiolucency or hyperlucency. Clear? So the moment you get the word lucency, it means there is lot of air. Clear? Lot of air, like in pneumothorax, but here it is involving both the lung fields, number one. Number two, what you can see, although not clearly seen in this, but if you see, right, so this is one rib, and say this is another rib, and there is very much increased distance between the two ribs, right? So this is actually the intercostal space. So there is widening of intercostal space, and that is mentioned as hyperinflation. So increased intercostal space, or the dimensions of intercostal space, right? So this is one thing. Then thirdly, look at the diaphragm. This is the diaphragm here. Clear? We can give it number 3. So this is the diaphragm. It feels as if it has been pressed downward. So this is known as low set or flat diaphragm. And fourth and most important, look at the shape of the heart. It feels as if the heart has been pressed from both the sides. So it becomes a vertical heart, or you can say a tubular heart. Clear? So these are 4 important points which one should remember: hypertranslucency, hyperinflated lung, low set and flat diaphragm, and fourth, tubular heart. If you find these 4 Muhammad Anas perfectly right, you are right. If you find these 4 features, definitely it's a X-ray or it's a case of emphysema. Clear? Then moving forward to another COPD condition, that is chronic bronchitis. Now here the diagnosis is clinical. And how clinical? We look for the symptoms. The first thing is productive cough. It means the patient will have cough with production of sputum. Now this presentation is not sufficient. It is the time duration which is more sufficient. So for this productive cough, the patient should give you a history of at least 3 months. Like suppose if it is December, he will say that I am having this productive cough since August or September. So like that. And then 1 year episode is not sufficient. It has to be for 2 consecutive years. And then you will ask whether you have the same symptoms last year. And then he will say yes, last year, even last to last year. So I am having this presentation almost every year, and it lasts for around 3 to 4 months. The moment the patient tells you like that, definitely is a case of chronic bronchitis. And this is especially seen in elderly smokers. But what is more important for you to remember, that it presents with central cyanosis, and therefore these patients are known as blue blotters. Clear? So these are few important differences between emphysema. Yes, Anas bhai, absolutely right. So this is few differences between emphysema and chronic bronchitis. Now since we have to take the entire medicine, so I am trying my level best to cover maximum things. And yes, I'll be sticking mainly to the clinical part. So I'll be skipping the pathology thing because it will make the class unnecessarily longer, right? So I'm sticking mainly to the clinical portion, right? And maybe in pathology review we can take all these pathological pearls, right? Now moving forward to bronchiectasis. Now ectasis means what? Ectasis means dilatation or swelling. Clear? So here what is happening? There is dilatation of bronchi or right? So you can see here, you can see there is dilatation of bronchi. Clear? Now the clinical presentation is quite obvious, because there is continuous productive cough, and the sputum is thick and tenacious, right? So this is classical thing, and the pathology is in left lower lobe. Now what is more important from medicine point of view is the imaging appearances. So here I would request all of you students to remember just 2 things. Number 1 is the tram track appearance, right? So number 1 is the tram track appearance, which is also known as railroad appearance. Okay, so this is classical tram track appearance, just like railway track, right? So this is tram track. And second is the signet ring appearance. So if you see here, and then you can have a something like this. Clear? So this is the classical signet ring. So very easy to identify. The moment you find these 2 findings, especially on high resolution CT scan, it has to be a case of bronchiectasis. Clear? Yes, Anash bhai, absolutely right. So this is HRCT showing 2 important signs, signet ring and time track. Then moving to cystic fibrosis, this is AR condition. It means it will affect only homozygotes, not the heterozygotes, which will be carriers. There is a defect in CFTR gene on chromosome 7. But what is more important clinically and how you will diagnose a case as a case of cystic fibrosis, the important pathology is that all the secretions in the body become very thick. Clear? So all the secretions in the body become very thick, and therefore we have the clinical manifestation. Suppose thick mucus in the respiratory passage will lead to pneumonia. Thick bile in the common bile duct will lead to secondary biliary cirrhosis. Then thick cervical mucus in the female will lead to infertility. Then because of this there can be bronchiectasis, and there is exocrine pancreatic insufficiency which will lead to osmotic diarrhea. Then there is intestinal dysfunction in the form of meconium ileus, and also we see abnormal sweat gland function. So you can see cystic fibrosis is a very multi-organ kind of disease. Then moving forward to Kartagener syndrome, and I think most of you must be knowing the triad of Kartagener syndrome, which is situs inversus, bronchiectasis, sinusitis, and infertility. So these two conditions, they are because of ciliary dyskinesia. Clear? And I think most of you must be good with situs inversus. If you look here, this is the apex of heart. Clear? So this is the apex of heart, and classically you can see it is on the right side. This is the left side, right? So you can see the apex, then you can see the ascending aorta, arch of aorta, right? So the right side structures are on the left side and the left side structures are on the right side, that is situs inversus. Then moving forward to another clinical entity, that is pleural effusion, which is collection of fluid in the pleural space. Now what will happen because of this? The moment you percuss, you will feel as if I am stroking a stone. It is so, that kind of note will come. So this is known as stony dull note, right? So stony dull note. And then if you auscultate, you will not hear the breath sounds because fluid is a bad conductor of sound. So these are two important clinical points which favors a diagnosis of pleural effusion. So if you have these 2 points in the clinical history, straight away you can jump to pleural effusion. Then there are two types of effusion. One is transudate and second is exudate. Now transudate is again because of two conditions. Either there is increase in hydrostatic pressure, clear, as we see in cases of congestive heart failure, or there is decrease in oncotic pressure, and this oncotic pressure is actually exerted by the proteins. And if there is hypoalbuminemia, as we see in minimal chain disease, there will be edema, right? So these two factors favors transudate. And exudate is usually taken for inflammatory conditions or any conditions which increases permeability of vessels. Permeability means leakiness. So the leakiness will promote outflow of the fluid from the vascular compartment, right? So these are the two varieties, transudate and exudate. So in transudate, the main cause are increased hydrostatic pressure or decreased oncotic pressure, and in exudate it is mainly inflammatory. Then what is more important for you to remember, that if you look for the serum, the fluid protein oblique serum protein, it will be less in transudate and it will be more in exudate. Now here the reason is that already the patient is having can be having hypoalbuminemia here. Okay, so this is one important thing. Then second is, of course, you can check the specific gravity, which will be high in exudate. And third, you can look for the difference of albumin content with blood albumin, and it will be more because in blood the albumin is already less because of hypoalbuminemia. So this is one thing, right? So these are 3-4 important differences which you can remember for transudate and exudate. But what is more important for you to remember is the basic mechanism behind the two varieties. Then moving to primary pulmonary tuberculosis. Now when we say the word primary, it means it is happening for the first time, and therefore it is usually seen in children's. Now when the, suppose this is lung. Now when the bacterium enters into the body for the first time, and suppose this is suppose this is upper lobe and this is the lower lobe. Clear? Now what happens, the bacterium, when it enters, it has a very peculiar tendency to go either here or here. So what I mean to say, either lower part of upper lobe, clear, or it can be upper part lower lobe. Fine. So this is for primary. Now this is actually subpleural lesion, and when we say subpleural, it means it is just below the pleura. So pleura is somewhat like this. So it is a subpleural lesion. So this is the site. Now this will heal, and this will lead to formation of Ghon's focus, and if we include lymphatics plus lymph nodes, it becomes Ghon's complex. Clear? So I think one should not confuse between what is Ghon's focus and what is Ghon's complex. Clear? Don't get confused in this. Now once this happens, the infection is localized and it remains latent, you can say, but there is possibility that over a period of time there can be reactivation. Clear? And then the bacteria will move out, and it prefers to go at the apex, right? So for secondary this is the preferred site. Clear? And this is for primary, right? So this is the difference between the sites of the two. And what else we see in secondary, there is one change which we don't see in primary, and that is cavitation. So cavitation is only related to post primary, or sometimes known as secondary. Clear? So it involves apex, and there can be cavitation if we take X-ray. So these are two things. And third is miliary, when the tubercle bacilli gains entry into the blood vessels. Clear? So it can go to any place, and especially in terms of lungs, it will give rise to miliary tuberculosis, where we will see dot appearance on both the lung feeds, right, around the size of 2 millimeter. So just 3 words: primary, post primary, and miliary tuberculosis. Clear? Just remember this much. Just for the sake of time, I am taking the important things which will help you actually understand what actually the question is all about. Of course, it's a sin to summarize the entire thing in such a short manner, but that is how we can do a rapid revision of medicine. Then moving forward to pneumonia. Now, how to diagnose a case of pneumonia? Patient will come with fever, high or fast breath rate, so it may be more than 18 breaths per minute. So in most of the slides, I'll be trying to give you an basic impression like how to diagnose a case from the MCQ stem about the condition, right? So like how, if there is a clinical history which includes this point, then you can say yes, probably this question is about pneumonia. So at least you can do one part correctly. So tachypnea, and then there is productive sputum. Now what is more important from pneumonia in exam point of view is the X-ray finding, and this is known as consolidation, right? So what you will find on X-ray, parenchymal opacity, and that is consolidation, right? So the moment you find the word consolidation or any appearance where you find a very white localized opacity, it has to be pneumonia, right? And that is known as consolidation in radiological terms. And please don't confuse it with pleural effusion, because pleural effusion is always on the lower part, because fluid has a tendency to gravitate down. Then moving forward to, I'll take only one important type of organism which will cause pneumonia, and that is Mycoplasma pneumoniae. And why I am interested in discussing this, because it will cause atypical pneumonia. Now I think most of you must be knowing what word typical and atypical are. Typical means usual presentation, and atypical means unusual presentation, away from the usual presentation. Like these are all for typical pneumonia: high grade fever, fast breathing, productive cough. But see what is happening if there is pneumonia because of mycoplasma. There is slight headache. What you can see here, no fever, clear, no productive cough. So the classical cardinal features of a case of pneumonia are missing here. And if you look at the respiratory rate, that will be normal, right? So respiratory rate is somewhere normal. You can say between 12 to 18 breaths per minute. And so clinically, he will not present to us in that toxic state. And again, if you look for WBCs, here we will find neutrophils count increased, but here neutrophil count will be normal on blood test. So this is again quite interesting that pneumonia is there, but it is not having those typical features which we see with pneumococcus or H. influenzae. So that's why I thought of keeping it here. Please remember Mycoplasma pneumoniae for atypical pneumonia. Clear? And one more important thing, if you remember about a little bit about microbiology of Mycoplasma, they don't have a cell wall. Clear? So smallest living organism, they don't have a cell wall, pleomorphic, then fried egg appearance on culture, right? Anyway, the fact which I am discussing here, they don't have a cell wall. This means that they are not responding to penicillin. Now, why they are not responding to penicillin? Because we know that the mechanism of action of penicillin is it acts against cell wall. So, if an organism is not having cell wall, then it cannot it cannot produce any effect. So, therefore, it is penicillin resistant. So this is again one very important point from yes, Shanawaz bhai, absolutely right. And therefore, any antibiotic which acts by destroying cell wall is ineffective in atypical pneumonia, especially caused by mycoplasma. Yes, we can give macrolides like erythromycin. Moving forward to another important cause of pneumonia, that is Pneumocystis carinii, which is also known as Pneumocystis jirovecii. This is again an opportunistic pathogen. It means it will become only active when the immunity falls too much, and we know one very important condition where the immunity falls very rapidly, very grossly, and that is AIDS. Now, from exam point of view, apart from this fact, you should know two more things. Number one is about the X-ray of Pneumocystis carinii, and here we will see bilateral, means both the sides, diffuse, means throughout the lung field, and infiltrates, especially if you can see here, all these white areas. Clear? So these are all important features in X-ray of pneumocystis carinii, pneumonia. And treatment wise, we can give cotrimoxazole. So just 3-4 points for pneumocystis are enough, right? Then moving forward to pulmonary embolism, which is secondary to DVT. Clear? So here, from here the embolus will go on and it will enter into the right side of the heart, and from here it will go into the pulmonary trunk, and as per the size it can go and it can involve any branch, right? So this is pulmonary embolism. Now the earliest and commonest presentation is dyspnea, that is difficult breathing, and most common sign is tachypnea, that is fast breathing. So this is tachypnea, and sometimes you will see that the patient is using accessory muscles for respiration. Now from exam point of view, just remember S1 Q3 T3 pattern. So S1 Q3 T3, it means we will see S wave in lead 1, right? Lead 1, then this is S1, then Q3, so we'll see a Q wave in lead 3, and T3, so we will see inverted T wave in lead 3. So just two leads you have to check, lead 1 and lead 3, and remember these S wave, Q wave and inverted T wave. And X-ray signs, one can see a Hampton's hump, then there is one Westermarck sign or Palla sign. Investigation of choice is of course CT scan, and we can classically see the thrombus within the pulmonary arteries. Although the gold standard is pulmonary angiography. Now this is not done because this is invasive. So we can study the entire pulmonary tree and we can locate the embolus. Clear? So gold standard is pulmonary angiography, but we prefer doing a non-invasive CT scan, which gives us valuable results. So why to go for invasive thing? Now moving forward to pulse. Now here, just this is all systole part. Okay, so this is all systole part, and this is all diastole. Clear? When we palpate a pulse, we will feel one peak here, and that is the percussion wave or tidal wave. Clear? So this is the percussion or the tidal wave, which is usually felt whenever we feel the pulse, right? Then there is a notch, and that is known as dicrotic notch. Clear? And then in the diastole there is one more pulse which is not felt, and this is the dicrotic wave. Clear? So this one is the dicrotic wave. So this is the wave pulse waveform. Clear? And what is more important, like we always feel this part, the tidal wave, which is in the systole. Now from exam point of view, you should remember 2-3 important pulses only. One is the water hammer pulse, which is also known as pounding pulse. Sometimes you might get the word Kartagener's pulse. Now what happens here, whenever we are palpating the pulse, there will be a very high volume pulse which will come, it will strike the examining finger and it will disappear suddenly. So that is water hammer, Kartagener's, or large bounding pulse. So here what is happening, the amplitude is more but the duration is short. So because the stroke volume is high, so it will strike the finger and it will go away. And yes, this is seen in aortic regurgitation. Then second type of pulse is pulsus paradoxus, which is actually exaggeration of the normal physiology, because normally what happens, if we check systolic blood pressure during inspiration, it falls, but the magnitude is less than 10 millimeter of mercury. But what happens in pulsus paradoxus, This is more than 10 millimeter of mercury. So inspiratory fall in systolic blood pressure of the magnitude of more than 10 millimeter of mercury is pulsus paradoxus, and therefore what we say, it is just exaggeration of the normal physiology. The thing which was supposed to be less than 10 now has become more than 10. Clear? So this is pulsus paradoxus. Now it can be remembered in two ways. Either there can be some lung conditions or there can be some heart conditions. Very good. So cardiac tamponade, constrictive pericarditis, very good. Right? So you can just write constrictive pericarditis also here. The list is always long, but I will not take the entire entities, just a basic introduction of that particular thing, right? So this is pulsus paradoxus, and the word paradox means that if you auscultate, you can hear the heart sounds, but if you palpate the pulse, you will not be able to palpate the pulse. So that is the paradox here. Then pulsus bispherians, right? Here the word bi is coming, and bi means two. So you can remember this 2 in two ways. There will be two peaks, right? So this is 2 coming here, right? So there will be two peaks, and both the peaks are in systole. Got it? So both the peaks are in systole. Now this is very important. So both the peaks are in systole. You can remember it like that. And second is, you can remember two conditions together, AR plus AS, right? So AR plus AS. So again you are getting two conditions together. Okay. So just remember pulsus bispherians, two upstrokes in systole, and two conditions like AR plus AS. Then moving forward to heart sounds, and I am more important in discussing the second heart sound because of that physiological beauty in which the two components of the heart sounds, that is A2 and P2, they vary with the phase of respiration. Like in expiration they comes closure, and during inspiration they move little wider or move a little apart, right? So now what is happening when this gap increases further in both the phases of respiration, that is known as wide splitting. So you can see here, during expiration the gap has increased, and during inspiration the gap has even become more wider. So that is wide. But on the other hand, if the gap has become more than the normal but it remains same in both the phases of respiration, you will call it wide but fixed splitting. Clear? So fixed means the gap between the A2 and the P2 is same in both the phases of respiration. Now here this condition is ASD, no other thoughts. Now in wide splitting, what you can remember, like A2 P2, this is the sequence. Now what can happen? Either the A2 is closing early or the P2 is closing late. Suppose if the P2 is closing late, so how we can write it? A2 will be here, but P2 is going so far, and this can occur in two conditions, especially right bundle branch block or pulmonary stenosis. Now why I am taking this example, why I am only taking this one, because sometimes what happens, sometimes there may be conditions like left bundle branch block. If we just reverse the conditions, left bundle branch block or aortic stenosis. So what will happen? The P2 component will close at the right time, but what will happen to A2 component? The A2 component will close later, and then we will get P2 A2, and this is what? This is reverse splitting, or also known as paradoxical splitting, right? So this is reverse or paradoxical splitting, and this is just because the aortic component is closing later than the pulmonary component, which is against the normal physiology of A2 P2. Now here it has become P2 A2. Clear? So this is reverse or paradoxical splitting, and yes, if it is A2 P2, that is wide, right? So just remember this basic concept, and it's a very valuable portion from the exam point of view, and most of the time we have question from reverse splitting, because the examiner just want to check whether you understood the concept or not. So if I simply write wide split S2, it can be pulmonary stenosis, it can be right bundle branch block, especially if it is affecting the pulmonary component. There can be early closure of aortic component based on clinical conditions. And for ASD, please remember the word wide and fixed, right? So this is the reverse splitting. You can see P2, A2 configuration of the second heart sound, right? So left bundle branch block, aortic stenosis, it means A2 closure is delayed. P2 is normal. Clear? And just give me a minute. Since last 2-3 days I am not feeling well, and therefore I was postponing the lectures like every other day. Now moving forward to one more beautiful condition, that is Wolff-Parkinson-White syndrome. Now what is happening here? This is, suppose this is atrium, this is ventricle, and normally there is a usual pathway like SA node, AV node, bundle of A's, bundle branches, Purkinje fibers. So this is the usual route of conduction of the signals. Now what happens, there is a shortcut, and this is actually bundle of Kent. So what happens, because of this shortcut, the impulses, rather than taking the longer route, they bypass the longer route and they quickly reach to ventricles. So this is creating a shortcut, and therefore we see a quick transmission of impulses to ventricles. So this is Wolff-Parkinson-White syndrome. Now how this is reflected on ECG, and the very first thing which everyone should remember is a delta wave. Now what is delta wave? Normally when we see the waves, the wave have to be something like this, right? But what happens in delta wave? Delta wave becomes something like this. Okay, so there is, and we call it slurring of upstroke. So this is known as the slurring of upstroke of the QRS complex, right? So this is slurring of upstroke. So this is the delta wave, classical feature of ECG of Wolff-Parkinson-White syndrome. Then I just told you that the wave, the impulses, they are taking shortcut to reach ventricle, and the pathway which suggests, or the interval in the ECG which suggests the time taken from the by the impulses to reach from atrium to ventricle, this is PR interval. Clear? So this is PR interval. So what is happening? Now normally it is 0.12 to 0.2 seconds. Now what is happening here? It is taking shortcut. So PR interval will be short. You will see a short PR interval. And third, the QRS complex will be widened. So these are three important ECG findings, which one has to remember for WPW syndrome. Clear? So slurred upstroke of QRS, that is delta wave, then wide QRS complex more than 0.12 second, and short PR interval less than 0.12 second. So very easy and very important to remember for WPW syndrome. And yes, you can give procainamide or flecainide or even amidron, or you can try radiofrequency ablation of this bundle of Kent. Now moving forward to rheumatic heart disease, again I will not be going into the pathology, please pardon me for that. I'll take the clinical stuff. Now major criteria, I think most of you must be knowing what are the 5 major criteria. So subcutaneous nodule, erythema marginatum. Now please remember it is erythema marginatum. Don't mix up with erythema infectiosum or erythema nodosum. Okay, so this is erythema marginatum. Then Sydenham scoria or St. Vitus dance, the carditis, and migratory polyarthritis. Now here I will take only one thing, and this word migratory polyarthritis, I am always fascinated by this word, because the clinical presentation is very unique. Like suppose if the patient is coming to us in December, he will say that there is pain in my elbow joint, and then he will come up for follow up maybe after 2 3 months. He will say that my elbow is okay now I am having pain in knee joint, right? And then maybe after again 2 3 months or later on, he will say now my knee pain is okay, I am having pain in hip joint. So the joint pain is migrating, it is changing its location. Clear? So this is the migratory polyarthritis. Poly word, I think most of you must be knowing, multiple. So this is classical thing, migratory polyarthritis. So please remember these 5 points. I think most of you must be having your own mnemonics. So this is joints, heart, nodules, erythema, sydenham, scoria. Now, equally important from clinical point of view, yes, Mohammed Anas, my mitral valve is classically and commonly involved. The minor criteria can be remembered by the mnemonic P's, where P is a past history of rheumatic fever. ECG will show a prolongation of PR interval, then arthralgia, then increased acute phase reactants like CRP and ESR, and fever, that is elevated temperature. So these are 5 minor criterias. Now what is more important from medicine point of view, like how you can make your diagnosis. Okay, you know the criteria, that's good, like, but presence of criteria isn't sufficient to make a diagnosis. You should know how much to choose from major, how much to choose from minor. So apart from these criterias, there has to be a previous streptococcal infection evidence. So that is a must. Once it is there, then only you will count the criteria. So what you can take, either 2 major, your diagnosis is okay. Yes, Caricum murmur, perfect. Either 2 major is there, but what if there is only 1 major? And in that case, you need to have 2 minors, right? So 2 major or 1 major plus 2 minor. So that is how, if you can club up these criterias, then only can say this is a given case of rheumatic fever. Now if you have okay, you have make your diagnosis. Now what is important, you have to give secondary prophylaxis so that there is no recurrent attack. And then there is there are different conditions, but from exam point of view, one should remember the prophylaxis in a patient who does not have carditis, and here we give penicillin, and the criteria is either give it for 5 years or till the age of 21 years, whichever is longer. So suppose if the patient is of 13 years, suppose, right? So if you give for 5 years, it will come out to be only 18 years. But you can continue it till 21 years, and here the duration of therapy will be about 8 years. So obviously this one is longer here. So we will follow this approach for this. Now take another case of say 19 years. Now if you give for 5 years, you will continue the treatment for 24 years. Now if you follow the concept of 21 years, now here you are giving the treatment only for 2 years. So which one is longer? Obviously this one is longer. So we will go for this approach here. So this is, there are 2 ways, either for next 5 years or either till the age of 21 years, and choose the course which one is longer. Yes, Anas bhai, group A beta hemolytic streptococcus. So this is especially for without carditis. Clear? Because if there is carditis, then your approach will change. You have to give secondary prophylaxis lifelong, right? So I'm not going into other details. The one which you should remember from exam point of view is that without carditis 5 years oblique 21 years. Clear? And we need to give benzathine, penicillin, and of course this has to be given after hypersensitivity testing. Don't inject penicillin without any hypersensitivity test, because there are few patients who are allergic and they may die. So after hypersensitivity testing, this is very important. Clear? And yes, it's written here, if it is allergic, then don't give injectable, simply switch on to oral. Fine. Then moving forward to infective endocarditis. Here in this image we can see a pea-sized nodule, right? So something like this. So this is actually Osler's node. So for Osler's, you can remember some peas, like painful pea-sized nodules at the pulp of fingertips. Then another painless condition is Janeway's lesions, which are painless, and these are found in sole and palms. Then in retina we will see Roth spots, and the condition which carries less risk of infective endocarditis is ASD, because it is a low pressure shunt, right, from left atrium to right atrium. Now again, a little bit of clinical stuff from infective endocarditis. There is one modified Duke's criteria. Now based on this we have question many times, and even in the last attempt also. So the mnemonic you can remember as B timer. The major criteria can be remembered with the alphabets B, and B stands for a positive blood culture which should be more than 2 times, and the culture are taken 12 hours apart. So conditions are very important. The culture has to be taken after there should be a gap of 12 hours between the 2 cultures, and both the cultures should show the growth of the organism. And then if we do echocardiography, there should be evidence of endocardial evidence, then only we will say it as endocarditis, right? And in minor criterias we have fever, temperature more than 38 degrees Celsius, then immunological phenomena which is indicative of infective endocarditis, and we have already discussed about Osler's nodes, Roth spot. Then microbiological evidence, like there should be a positive blood culture which is not fulfilling the major criteria. So microbiological evidence. Then embolic phenomena is a minor criteria, like arterial emboli, septic emboli, or conjunctival hemorrhage, or painless skin lesions, which are Janeway lesion. And then risk factors like a congenital heart condition or a history of IV drug abuse, right? So these are 2 majors and 5 minor criterias under Duke criteria for infective endocarditis. And please don't mix up Jones criteria of rheumatic fever with Duke's criteria of infective endocarditis. Again, for diagnosis we have to count these criteria. So what we can do, either we can take 2 major, right? So 2 major, in fact we have only 2 major, so that are sufficient to make a diagnosis, or 1 major plus 3 minor. So 1 major plus 3 minor, or if we don't have any major, no problem, we should have all 5 minors. Clear? So either all of these, if not then 1 plus 3. Clear? So this is how we can reach up to a diagnosis of infective endocarditis, and from medicine point of view this is extremely important. I am requesting all of you to please memorize it by any means. Then moving forward to some valvular conditions, and the classical one is, in fact the most common condition which you will see in clinical practice, is mitral stenosis, and most cases are secondary to rheumatic fever, of course. Now this condition presents with complications. It can be AF, where the heart rate is more than 350 beats per minute. Clear? And what you will see on ECG will show absent P waves. Clear? So this is atrial fibrillation. Then there can be coughing out of blood, that is hemoptysis. Then because of backflow of blood there will be pulmonary hypertension, hoarseness of voice because of involvement of recurrent laryngeal nerve. Then what is more important from medicine point of view is the murmur, right? So we hear a mid diastolic murmur. Clear? We hear a mid-diastolic murmur, and prognosis wise there is one term, and that is known as opening snap. So suppose if this is the second heart sound and this is the opening snap, so this is S2, of course E2 P2, I'm just writing it as a single. This is opening snap. Now this gap is prognostic, because as this gap keeps on narrowing, it indicates severity of the lesion and the prognosis becomes more and more bad, right? So this is what I have written. S2 opening snap gap is prognostic, means lesser the gap, poor the prognosis. Clear? So this is very important here. So remember this. And the normal surface area of mitral valve is 4 to 6 centimeters square, and if it reduces down to 1/10, chances of life are very less, in fact 0. So in short about mitral stenosis, I'm not going to treatment part because that will make the presentation a lot of lengthy. Clear? Then moving to aortic stenosis. Now how to identify it in your question? There will be angina, and yes, there is possibility of sudden death. And there is narrow pulse pressure. Now what is pulse pressure? This is systolic blood pressure minus diastolic blood pressure. And in aortic stenosis there can be sudden death, so we always say please don't do any exercise testing. So it is contraindicated. So don't do any exercise testing. Yes, there will be systolic murmur. Then moving forward to another important condition, and that is aortic regurgitation. Now here what happens, the blood, when it is pushed from the left ventricle to the aorta, rather than moving forward into the aorta, it comes back into the left ventricle. So what we'll see, one thing we have already discussed, a collapsing pulse or a water hammer pulse or a Corrigan pulse, and widened pulse pressure. It means the difference between the systolic blood pressure and the diastolic blood pressure is more. And what else we can see here? Now this phase is diastole. Okay, this is all diastole. This is systole. Between S1 and S2, this is systole. Clear? And this phase is diastole. So what we can see? We can see a diastolic murmur. So there is a decrescendo diastolic murmur. Now what is this word decrescendo? Now decrescendo means initially the murmur was like this, but later on it becomes this. So it is decreasing. So this is known as decrescendo. Clear? So decrescendo means it is decreasing in intensity. Clear? Yes, we can see Austin Flint murmur as well. So this is decrescendo diastolic murmur, and then it can be seen in Marfan syndrome or aortic dissection. So this is in short about AR. Then moving forward to mitral regurgitation, which can be seen in mitral valve prolapse, and we see a hollow systolic murmur. When we say hollow systolic, because we know this is all diastole. Okay, so this one is all diastole and this one is systole. So we can see the murmur is extending or throughout the systole. So it is known as holosystolic or pansystolic murmur. Clear? So this is mitral regurgitation. Then moving to heart failure, it can affect the left side, it can affect the right side. If it affects the left side, the manifestations will be pulmonary. So there will be dyspnea, that is difficulty in breathing. There will be orthopnea, that is difficulty in breathing on lying down. There can be paroxysmal nocturnal dyspnea, means there will be paroxysm of dyspnea at night, and there will be cough. So what you can see here, pulmonary manifestations. In right side, yes, very good. On right side, the manifestations will be in the venous major veins and the organs like liver. So this can be tricuspid, there can, especially in case of tricuspid regurgitation, we can find a pulsatile liver, where the liver will move up and down with every systole. So there will be peripheral edema, elevated JVP, Kussmaul sign, and enlargement of liver. Now, what is this Kussmaul sign? It means, like, normally what happens, JVP column falls during inspiration, right? So during inspiration it falls because there is a negative intrathoracic pressure and the blood is sucked downwards. But in Kussmaul sign, this normal phenomena is not seen. The JVP remains elevated even during inspiration, right? So that is Kussmaul sign. Then moving forward to one very beautiful condition, that is HOCM. So hypertrophic obstructive cardiomyopathy. Now the name is suggesting the explanation. So hypertrophy means there is hypertrophy of which structure? This is interventricular septum. Obstructive, where is obstruction? Obstruction to flow of blood from left ventricle onward. And cardio is heart, myopathy is myo is muscle, and pathy is problem. So even we can just, so myopathy, clear? So classical explanation. So now what is happening here? You can see here, this is the interventricular septum, which has asymmetrically thickened, and it reduces the size of the left ventricle. So what we say, there is left ventricle outflow tract obstruction. So the blood cannot move from the left ventricle to aorta properly. So one problem is diastolic dysfunction. It means the blood cannot come from left atrium to left ventricle normally, right? So diastolic dysfunction, and the blood cannot go from left ventricle to aorta. So this is systolic dysfunction, clear? So overall physiology is yes, Anas bhai, the cavity is banana shaped, good. So this is having both primary diastolic, secondary systolic dysfunction, clear? So now the important thing is sudden death, and yes, it can be seen in athletes. So many times we have seen cases where somebody is doing very heavy activity and he suddenly collapse. So that could be a case of HOCM, although aortic stenosis can also be a possibility there. Now what we see on echocardiography, we will see apart from this asymmetrical septal hypertrophy, this is known as ASH, clear? So this is ASH, asymmetrical septal hypertrophy. Okay, so this is why we are saying asymmetrical, because it is involving more, it is going more into the left ventricular cavity. Okay, so asymmetrical septal hypertrophy, clear? So this is ASH, and when we will do echocardiography, we will see that the because of this disturbed anatomy, the mitral valve will not be able to function properly, right? So there is systolic anterior motion of mitral valve leaflet, and since it is not able to close properly during left ventricular systole, so the blood will move back into the cavity of left atrium, right? So this is also one problem here. So this is MR into the left atrium, clear? So this way you can say that even the systole is not properly pushing the blood into aorta, some part is going back into the left atrium. So this is diastolic plus systolic dysfunction, clear? Now treatment, you can give propranolol, But what I want to tell you from exam point of view, that what is not to be given. So remember 2Ds: digoxin, diuretics. Never give these drugs, and of course tell the patient to avoid strenuous activity. Clear? So avoid strenuous activity. So in short about HOCM. Now moving forward to angina, there one variety is springmental angina, which is also known as variant angina, because whenever we discuss angina we always think that there might be some coronary artery occlusion, and then the features of angina will come. But here there is nothing like atherosclerosis or lumen narrowing of lumen of the coronary arteries. It is just because of vasospasm. Clear? So spasm means constriction, and this usually occurs at midnight, or you can say early morning. And one more important difference is that it is not related to exercise. Usually the angina of the atherosclerotic thing comes with exercise, emotions, or eating, but here it is unrelated. And on ECG we will see ST segment elevation, because usually we say that angina don't have ST segment elevation. ST segment elevation is a feature of myocardial infarction, but this variant is very unique in this part. Then moving forward to chronic but stable angina. Now when we say stable, it means that the biomarkers are normal, pain will come but it will go away with rest or nitrates. So there is retroesternal chest pain, and this is precipitated by 3 E's, that is exercise, emotions, and eating, and it typically relieves with either nitrates or batrates. So this is stable, and this is shown if there is more than 70% blockage of the coronary artery. Now if there is change in this routine pattern, we will call it unstable angina. So either the frequency of the pain is increased, either the duration of the pain is increased, either the pain is coming on less or no exertion, and either the pain is not responding to rest or treatments, then we will say that now the stable variety is moving towards unstable angina. Now moving forward to myocardial infarction, what you need to look in ECG, of course the very important thing, if there is an ECG based question, you need to look for ST segment elevation. And I think it is not that difficult to understand what ECG or what ST segment elevation is there on the ECG. So if you draw a straight line, the isoelectric line, you can clearly see that the ST segment has moved upward, right? So if you draw something like this, so you can see that the ST segment has gone upward. So this is ST segment elevation. Now in question you can have like you might have to understand, or you might have to answer the site of MI. So for that you need to read the entire 12 leads ECG, and based on the ST segment elevation you can answer that whether it is lateral, whether it is anterior, whether it is septal, or whether it is inferior. Suppose for example I have taken anterolateral infarct. So here what you need to do, firstly you need to see where the anterior leads will show you ST segment elevation, that is V3, right? So V3 and V4. So for anterior you need to check V3 and V4, and for lateral you need to study many, lead 1 and then AVL, V5 and V6. So 1 AVL, V5, V6. Clear? So if you find ST segment elevation in all these 6 leads, then only you will say that it's a case of anterolateral infarct. Suppose if you find only in lead V3 and V4, you will call it anterior. If you find it, suppose if you are finding ST segment elevation, so this reading ECG is very important. And I'm like, I always expect that like only these kind of questions should come if it is ECG based. So some selective topics, because otherwise ECG is a very tough segment. So suppose if there is ST segment elevation in V1, V2, now you will simply call it septal MI. Apart from this, if there is involvement of V3 and V4 as well, then now this is anterior, and if you find in all four, then your answer will be inclusive, so it will become anteroseptal. Got my point? So this is how you need to read all the 12 leads, look for ST segment elevation. Just remember this particular box. Yes, you have to understand, like if it is in lead 2, 3 and AVF, this is inferior, then this is lateral, clear, then this is septal, and of course for anterior you cannot draw lines, right? So please remember this, and there is no significance of this. So if you remember this diagram, I am very sure you can mark it out. So please remember it. Then markers in MI, I think all of you must be knowing, is all theoretical, nothing to teach in detail. So stable, all normal. What you need to check, troponins, like for troponin T, it will start somewhere by 4 to 6 hours, will peak somewhere by 12 to 24 hours, and back to normalcy by 7 to 10 days. So you can remember it for all the markers. I've just given you one example. Then moving forward to cardiac tamponade. Now there is a pericardial effusion, which is the fluid in pericardial cavity, and another entity is cardiac tamponade. Now what does tamponade means? Suppose this is the heart, okay, then if there is any sudden collection, massive collection outside the heart, it will press upon the heart and it will prevent the usual functioning of the heart. So this tamponade is actually pressure effect. So that pressure effect is the whole cause of problem. And here this is, you can say, rapid accumulation of pericardial effusion, and yes, a classical backstride where you will find decreased blood pressure. Then in the image you can see raised JVP and silent heart sound, which is also known as muffled heart sounds. Again, the concept is quite obvious. There is collection of fluid around the heart, so that's a bad conductor of sound, and you will, when you will hear, you will feel as if the heart is beating at a very distant place. So muffled heart sounds. Now features, pulses, paradoxes, we have already discussed that the fall in systolic blood pressure on inspiration will be more than 10 millimeter of mercury. On JVP, now this is a question which is repeated over the years, absent Y descent, clear. And yes, on X-ray we will see a money bag appearance on X-ray, yes. So this is the thing. So we will see a big globular heart, or you can also call it money bag appearance, clear. So this is all, collection in the pericardial cavity, clear. And this is the heart shadow, right? Now many times in exam I have seen that there is a question and the students are usually confused whether it is cardiac tamponade or constrictive pericarditis. So one thing is quite very important, is that absent Y descent on cardiac tamponade, but the cardiac descent is steep in constrictive pericarditis. So one important difference is in terms of the Y wave, which is absent in cardiac tamponade and present or steep in constrictive pericarditis, right? Then second is pulsus paradoxus, which is present in cardiac tamponade but it is absent in constrictive pericarditis, right? Then third is Kussmaul sign, which is present in constrictive pericarditis but is not seen in cardiac tamponade, clear. So these are three important points which one should know by heart. So JVP in relation to Ahmed Bhai, I'll look into that, right? Don't worry. So there are only 3 points which you need to remember for distinguishing cardiac tamponade from constrictive pericarditis. One is JVP, second is pulsus paradoxus, and third is Kussmaul's sign. Clear? So it's up to you how you memorize this table. So Kussmaul sign we have already discussed. So now we move forward to hematology. Now for iron deficiency anemia, again I will not be going into the majority of the things because I think most of you must have covered it in pathology. Now what is more important from clinical point of view is that earliest sign, and this is a fall in serum ferritin, because ferritin is the iron storage. So if there is iron deficiency, the storage will start depleting, and therefore it becomes the most sensitive and specific test, right? So if you suspect a case of IDA, the very first entity you should order is ferritin. Yes, Shanawaz bhai. And apart from decreased serum ferritin, there is one parameter which is increased in IDA is total iron binding capacity. So if you find these 2 points, your diagnosis of IDA will be well made, right? So high TIBC and low serum ferritin. Then megaloblastic anemia, what you need to remember, multi-segmented nuclei. It means in neutrophils, normally they have 3 to 5 lobes. Clear? Here the lobes will be more than 5. Fine. So this is how you can see. Then one neurological condition which is associated is subacute combined degeneration. And therefore we always say that if you treat a case of megaloblastic anemia, always give vitamin B12 plus folic acid together, because if you give only folic acid, anemia will correct, but neurological signs will worsen, right? So worsening of neurological signs. So never give folic acid alone. Clear? Need to add vitamin B12. Then tongue will show large red tongue, so macroglossia, atrophic glossitis. Hemolytic anemia, it means there is breakdown of RBCs, and what will happen? Body will try to produce new RBCs, and those new RBCs are actually the immature forms, that is the reticulocytes. So there will be an increase in reticulocyte count, so which is what we call it reticulocytosis. Then the breakdown products of RBC, they will combine with haptoglobin. So the amount of haptoglobin will fall in the body. So decrease serum haptoglobin levels. Then sickle cell anemia, I think most of you must have read in pathology that glutamate is replaced by valine at beta 6, and the most common presentation is actually bony pain, that is actually because of vaso-occlusive crisis, which is also known as painful crisis, and that is precipitated either by infection, dehydration, deoxygenation, or also you can say acidosis. So the RBCs, they assume a sickle cell shaped, and as they move forward they will cause occlusion, and one such area is spleen, and therefore initially there may be splenomegaly, but later on because of these infarctions, finally there is shrinkage of the spleen, and that is known as autosplenectomy. Clear? And then there can be a plastic crisis which is precipitated by parvovirus B19. Then hereditary spherocytosis, this is a RBC membrane defect, especially because of ankyrin, and since these RBCs, they become spherical and they cannot pass through the splenic sinusoids, and here they become they hemolyzed. So what is happening? Spleen is the site of RBC breakdown. So what we need to do? We need to sacrifice the spleen. So splenectomy is done, but give pneumococcal vaccines. Otherwise there will be overwhelming post-splenectomy infection, right? So this is hereditary spherocytosis, and very easy to identify on peripheral blood smear, because normally when we see RBCs, not this bad, sorry, like this, there is a central pallor slide, right? So there is a central pallor, but in hereditary spherocytosis it is all dark, no pallor. Clear? Then PRV, that is primary polycythemia. Okay, and here what is important for you to remember is erythropoietin level, which can be normal or even low. This is how we differentiate primary from secondary, because in secondary polycythemia erythropoietin is always high. Clear? So this is one way of differentiating the two conditions. And there is hyperviscosity, there might be bleeding, raised leukocyte alkaline phosphatase score. Hemophilia factor 8 levels affect males. Patient will come with swelling in knee joint especially. And when I say male, I think most of you can answer that it is XLR inheritance. Then Waldenburg disease, it is the most common bleeding disorder, and inherited bleeding disorder. There is prolongation of bleeding time and activated partial thromboplastin time. Prothrombin time is normal, and here also the clinical presentation is somewhat similar to hemophilia, but the important thing is that it affect females also, because it is autosomal dominant. So it can affect anyone. Just one abnormal gene is sufficient to manifest, and treatment is by cryoprecipitate, which is rich in factor 8. Moving forward to Hodgkin's, and here you can see enlargement of cervical lymph node, and if you feel the lymph node, it will be rubbery. So it can be related to Epstein-Barr virus. Reed-Sternberg cells are the malignant cells which are positive for CD1530, except in lymphocytic predominant. Most common is worldwide is nodular sclerosis. In India it is mixed cellularity, and lymphocytic predominant is histogenetically different, because it is not positive for CD15 and 30, it is positive for CD20. But lymphocytic predominant carries best prognosis, because prognosis in Hodgkin's lymphoma, it depends on number of lymphocytes. Clear? Number of lymphocytes. So therefore, lymphocytic predominant, best prognosis. Lymphocytic depletion, poor prognosis. So this way you can remember, right? So poor prognosis. Then you can remember AVDB and MOP regimes for treatment. Yes, Shahnawaz bhai, all eye appearance. Then moving to thrombotic thrombocytopenic purpura. Here you need to remember two things. The term is thrombocytopenia, so you can say platelet count will be low. And second important thing is that there is microangiopathic hemolytic anemia. Now because of this hemolytic anemia, RBC count will decrease. So two important findings: low platelets, low RBCs, right? Apart from this, there can be fever, neurological symptoms, and renal failure. So this is the pentad of thrombotic thrombocytopenic purpura. Then hairy cell leukemia, you can see hair-like projections. Okay, so you can see something like this. So very easy to identify if an image is given. Clear? So hairy-like cytoplasmic process, and this is from B cell, and cladribine is the treatment. Now temporal arteritis, as the name suggests, temporal, this is actually superficial temporal artery. Clear? And seen in females, patient can have severe headache because of this artery. There can be blindness. There is jaw claudication, that is difficulty in pain on chewing. Then we need to make a biopsy. Yes, unilateral headache, jaw claudication, very good. We need to do a biopsy because we are going to give steroid for a longer period of time. So biopsy is needed to make a confirmed diagnosis. Then for SLE, different system, you will find different findings, like musculoskeletal, it is non-erosive. In renal, we will see wire loop lesions, and in lungs, we will see shrinking lung syndrome. And in fact, renal involvement is the most common reason for diagnosis. And yes, malar rash. Then specific antibodies, anti-double stranded, anti-Smith. Then for enoch-Schonlein purpura, there is abdominal pain, glomerulonephritis, and yes, Shanawaz bhai, absolutely right. So enoch-Schonlein purpura, arthralgia, abdominal pain, and glomerulonephritis. But what is important here? See, platelet count is normal, right? So normal platelet count as compared to reduced platelet count in thrombocytopenic purpura, right? So this is one important clinical point to differentiate enoch-Schonlein purpura from thrombotic thrombocytopenic purpura. Now moving forward to myasthenia gravis, and here we need to understand the basic structure of a synapse first, especially a neuromuscular junction. Like what happens? This is presynaptic area, and presynaptic area has vesicles which contains neurotransmitters. And neurotransmitter here is actually acetylcholine. Now this acetylcholine will cross the synaptic cleft. This is all synaptic cleft or the space, and it will bind to the receptors. Clear? So it will bind to the receptors, and the information will be move forward. Now what happens in myasthenia gravis? There are antibodies against these receptors. So these receptors are destroyed, and therefore the myoneural junction transmission proper does not happen. So decreased myoneural junction transmission. Then I think the clinical features are quite obvious. It can be generalized, or it can be ocular. So there can be dysarthria, muscle weakness, ptosis, of course, in ocular variety. And here it's only related to neuromuscular junction, so sensory modalities, DTR. It has nothing to do with the upper motor neuron kind of lesion, right? So no findings suggestive of that. And since it is related to thymoma, so we have to remove thymus gland. Now here the classical thing is the symptoms are more during evening hours. Clear? So it means that the person will have symptoms more during the evening hours, and there is a little bit similar condition, and that is Lambert-Eaton syndrome, right? So Eaton-Lambert syndrome or Latin-Lambert syndrome. Now there are a couple of differences which you should know between the two conditions. Number one is in terms of pathology. So in myasthenia gravis, the pathology is at the level of receptor, because there are acetylcholine receptor antibodies, right? But in case of the Lambert syndrome, the problem is with the calcium channels. So there are antibodies which are directed against these volt-gated calcium channels. Clear? Then thymic tumor is associated with your myasthenia gravis. Then small lung cancer with Lambert-Eaton syndrome. And classically, the weakness worsens on prolonged exercise, and therefore the symptoms are more marked in the evening time. But in contrast to this, weakness improves on prolonged exercise in Lambert-Eaton syndrome. So this is a very important clinical point to differentiate the two conditions. Now, DTR are normal in myasthenia, but DTR may be decreased or absent in Lambert-Eaton. Then there is, if you do repetitive nerve stimulation, there is decremental response in myasthenia, but the response is opposite in Lambert-Eaton, that is incremental response, right? So these are 2-3 important differences which you should remember, and then your question will never be wrong in relation to this entity of neuromuscular junction, right? So myasthenia gravis, and therefore you might have seen many number of times we have a question from myasthenia gravis or Lambert-Eaton syndrome. Then Duchenne muscular dystrophy, I think most of you must be well versed with the fact that usual presentation is a male boy, so it is XLR. The problem is in dystrophin gene. If you look at the muscles, they look very bulky, but when you will check the power, it is extremely less, and therefore we use the word pseudo hypertrophy. And when you tell the patient to stand up, he will need support at every step. So you see support at every step, and this is climbing on himself, right? So this is the typical Gower sign system of DMD. Then moving forward to myotonic dystrophy affecting 19q, and there is high incidences of cataract, then premature balding, and then gynecomastia or testicular atrophy. So myotonic dystrophy. Moving forward to celiac disease, which is because of sensitivity to protein gluten, which is present in wheat, barley, and rye. And therefore when patient will consume any of these food stuff, he will develop diarrhea. And it's bimodal. It can be seen in infants less than 1 year, or it can be seen in third decade. Now we have two methods to diagnose celiac disease. Either we can go for antibodies or we can go for biopsy. Of course this is more diagnostic or most preferred one. And here what you'll see, we'll see loss of villus, so that is total villus atrophy, and at the same time we will see hyperplasia of Krebs. The thickness of mucosa is unaltered, and there is one skin condition related to this, and that is dermatitis herpetiformis. Clear? And this condition needs to be treated by Dapsone. Clear? So this is in short about celiac disease. Crohn's disease, you can see the classical skip lesions. So these are involved areas, and these are the intervening normal areas. So it seems the disease is skipping something like this, right? So this is skip lesions, there is creeping fat, ASCA antibodies, and we need to give 5-L-minosalicylic acid. Then in ulcerative colitis, we will see a continuous lesion, and there can be toxic megacolon or pseudopolyps. So just to differentiate between the two entities, in Crohn's we see skip lesions. In ulcerative there is continuous involvement. Then Crohn's can involve any part of GIT, especially terminal ileum and ascending colon, but ulcerative colitis is especially related to rectum and sigmoid colon. Then pseudopolyps are common in ulcerative colitis. Then fissures and fistula are common in Crohn's disease. Then one important thing is transmural. It means the entire thickness of the gut is involved in Crohn's, but it is a mucosal and superficial mucosal lesions of ulcerative colitis. Granulomas are seen in Crohn's but not in ulcerative colitis, right? So just few basic differences between the two. Now if you talk in terms of imaging modalities, you can remember sting sign of Cantor here. Clear? And here you should remember lead pipe colon. This is because of loss of hostrations. Clear? So this much is enough. Now important segment is markers for hepatitis B virus infection. And what is more important for you to remember is one is acute hepatitis B infection, where there is one is hepatitis B surface antigen, and there is presence of IgM anti-HBsAg. In chronic, HBsAg plus IgG HBsAg. So if you just write it like slightly confusing in this table. So suppose if we write acute hepatitis B virus, then of course we write anti-HBc, because we don't see core antigen. We never see core antigen. We always see antibody to core antigen, right? So here this will be present, and this will be IgM. If we write chronic hepatitis B virus, of course this will be present, and this will be IgG, right? So this is how you need to differentiate acute from chronic. Now the third thing is infectivity. In infectivity, we need to add two. One is envelope antigen, and second is hepatitis V viral DNA. If these two are high, the patient is highly infective. It means virus is actively multiplying in the body, right? So patient is highly infectious. And obviously, if there is anti-HBeAg, you will say that the patient is non-infectious. And there is one anti-HBs, that shows immunity. Now immunity can be because of vaccination, or it can be because of previous infection. So here, if it is because of infection, we will see only anti-HBs. But if it is because of infection, we will see anti-HBs and of course IgG anti-HBc. Clear? So this is in short how we can interpret the markers, right? So you can see here in vaccination there is only one marker which you will see in blood, that is anti-HBs, and in case of cleared infection you will see anti-HBs plus IgG anti-core antibody. Clear? So this is, you should remember, most of the time the question is from this only. Then Wilson disease, I think most of you must have already read. This is autosomal recessive, and there is increased level of copper which can be excreted in the urine as well, and this is known as hepatolenticular degeneration. So there is liver dysfunction, there are Kesher-Fleischer rings in the Descemet's membrane of the cornea which does not interfere with the vision. Then there is neurological manifestations also. We need to give zinc acetate or zinc gluconate, and if a person is not tolerating this, then we can go to second line drug, that is trientine. Hemochromatosis, there is excess of hemosiderin in the skin, and that gives its bronze skin. And since this condition is also associated with diabetes, so sometimes we call it bronze diabetes. Clear? So this. Then there can be involvement of joints or pseudo gout, right? Or even heart. Treatment, we need to do venesection or phlebotomy, and we need to remove around 500 ml of blood every week. Chelating agent is desferoxamine. Then moving forward to minimal chain disease, then the term minimal chain disease was given looking at the light microscopy changes where there was no change at all, but when it was studied under electron microscopy, it was found that it's wrong to say that there are no changes. There is fusion of or effacement of food processes, and this condition responds dramatically to steroid. Of course, this is the most common cause of nephrotic syndrome in children's. Clear? Then RPGN, that is rapidly progressive glomerulonephritis, which is also known as crescentic GN. And as the name suggests, this condition is very rapid and it can present with acute renal failure within 3 to 6 months, and on microscopy we will see crescent formation, right? So suppose if this is glomerulus, we will see a crescent somewhat like this, and then here is all glomerular tissue. So this is the crescent formation, something like this. Clear? So this is the crescent. Then renal artery stenosis, you can classically see there is a narrowing of the renal artery. It is maybe because of atheromatous plaque in the middle aged, but in females it is usually because of fibromuscular dysplasia. And what we can see, this is renal artery stenosis. Okay, so suppose if this is the normal lumen, the artery is somewhat like this, and we can do a magnetic resonance angiography. Moving to primary hyperparathyroidism. Now, when we use the word primary, it means we are talking about parathyroid glands only, because it can be secondary when it involves the other areas. So this is parathyroid, and here it is because of solitary tumor of the parathyroid. And what you need to remember: bone, stone, groans and moans. So there are brown tumors, there are renal stones, peptic ulcers producing abdominal groans, and depression, that is psychic moans. Since it is excess of parathyroid, so it is going to increase the amount of calcium. So raised calcium, low phosphate, and normal to increase alkaline phosphatase. Addison disease, this is insufficiency of adrenocortical axis, and one of the hormone which will be low here is aldosterone. And we know that aldosterone, the work is to increase sodium in the body and to decrease potassium in the body, right? And what will happen then? If this is low, obviously this will be low, this will be high. So there is hyperkalemia and hyponatremia, right? And there can be pigmentation. Conn syndrome is opposite to this. So there will be excess activity of aldosteronism. So there will be high sodium, that is synonymous with BP, so hypertension, and excess of potassium will be removed from the body, so decreased potassium, that manifests as myopathy. Then important part is aphasia, which can affect the motor area, that is Broca's area, or it can affect the sensory area, that is Wernicke's area. Now sensory aphasia is when the patient is not able to understand what is being asked, but whatever he will say it very fluently. So in sensory aphasia, we can write it in two terms. One will fluency, and second is relatedness to question. Clear? So in Wernicke's, fluency will be there, but the answer is not related to the question asked. And what happens in Broca's? Fluency is not there, but obviously the answer is in relation to the question asked, right? So this is how you need to remember the two entities. Broca's, which is also known as motor aphasia, if there is an injury here. So this is motor aphasia. And if there is injury to Wernicke's area, that is sensory aphasia. Clear? So just remember this much. It has been asked many number of times. Then cerebellum, it's related to coordination between muscles. So many times we will see ataxia, that is loss of coordination between different group of muscles. So there is no production of a smooth and accurate muscle. Muscle tone is less, that is hypotonia. And intention tremors. It means when the patient will try to do something, then only the tremors will come. One should not confuse it with resting tremors of Parkinsonism, in which the tremors are coming even if the patient is doing nothing. And there can be ocular movements in the form of nystagmus. And here there is one more term, diadochokinesia. Like if you tell the patient to do supination, pronation rapidly, he will not be able to do those rapidly alternating movements. So that is dysdiadochokinesia, should be remembered for cerebellar lesion. Then meningitis, I think most of you must be perfect with this. Like in bacterial meningitis, in CSF sample we will see plenty of neutrophils. In tubercular we will see plenty of lymphocytes. And the only thing in terms of, you can write gross here, we will see a cloudy CSF here, and we can see a cobweb appearance here. Clear? Sugar will be always less because it is eaten up by bacteria. Then moving forward to Parkinsonism, we already discussed that is tremors at rest. There is fascinating gait. It means the patient will take a very short step. He'll be stooped, taking short step, and will be walking very fast as if he is trying to catch a center of gravity. There is a slowness of movement, that is bradykinesia, and that also manifests as decreased blinking. Face is expressionless, so also known as mask facies. Then there are certain drugs, and of course there can be pill rolling movements or pill rolling tremors. Some drugs, they are notorious to cause these extrapyramidal side effects like methyl doparazepine thiazides or metoclopramide. Then moving forward to extradural hemorrhage versus subdural hemorrhage, just 2-3 differences which you should know. That extradural is arterial, subdural is venous. Clear? Then second is there is a lucid interval in extradural, and there is no concept of lucid interval in subdural, right? And then this extradural is limited by cranial sutures, and the subdural is limited by the dural folds. And in the shape on CT scan, you can see biconvex like this, and here it will be concavo convex. Clear? So just 3 points to remember from exam. These 3-4 points are enough. Clear? So extradural and subdural. Yes, you can make your idli banana fine. Then subarachnoid, right? Here we know that in subarachnoid space there is CSF. So whenever there is subarachnoid hemorrhage, the blood will go and it will mix CSF. So it will, if you do a CSF study by doing lumbar puncture, you will find blood mixed CSF. Clear? So that's very important. Apart from that, one should remember that it is mostly because of rupture of Berry aneurysm, which usually involves the circle of Willis, and the classical presentation is of thunderclap headache. And on CT scan you will see the enlargement of the cisterns, which are usually filled with CSF. Clear? So not difficult to diagnose. Then moving forward to Guillain-Barré syndrome, this is a very beautiful condition because the prognosis is extremely good, right? So it is an ascending type of motor paralysis, means the problem will start from the toes and it will ascend upward to knee and then to hip. And the classical presentation is that patient will come to us and he will say that whenever I walk, my footwear slips off from the feet. So that it shows that the distal muscles are paralyzed, right? And it can be a secondary to Campylobacter jejuni infection, right? It can be secondary to this, or then it presents with lower motor features like areflexia and flaccidity, of course. Then on CSF examination we find albumiноcytological dissociation, because usually when we study in other meningitis forms, there is a increase in protein and there is increase in cell count. It can be neutrophil or lymphocytes, but here there is increase in protein but there is no increase in any cell count. So that is known as albumiноcytological dissociation. Treatment wise, we can do plasmapheresis or we can give intravenous immunoglobulin, right? So coming to the diagnostic criteria, there is flaccid paralysis, typically a lower motor neuron kind of uh, presentation, right? And there is side to albuminal dissociation, of course. So this is enough for GBS from exam point of view. So this is enough from my side for rapid revision of medicine, and I am very sure that I am very sorry that there are many more topics which should be discussed, but since it's a rapid revision, so I have to choose only the ones which I personally felt like very important to discuss with all of you. So with these words, I take permission from all of you,